Good morning, everyone. It is 10 o'clock and time for our weekly coronavirus virtual information session. I want to welcome everyone to this session this morning. I believe it's going to be a very interesting session to talk a little bit about our long-term care facilities and some of the issues that is going on there. So welcome. And I want to just make sure that you please keep your microphones on mute. And if you can always write any questions you have. You can type in the chat, or you can raise your hand and ask the question. And then there's some phone numbers you can call if you are concerned about anything related to your health. Next slide, please, Justin. Also make sure that you see here at the left corner at the bottom where you can unmute and mute yourself and start your video if you need to. Then the next slide, I want to make sure that we also yet again know where everyone comes from. So if you can do me a favor and just type again for me what county you come from, that helps us for our census to see how far we reach. So with that, I'm going to hand it over now to Dr. Furman. I already have some people in the chat who say they have a lot of questions for you, Dr. Furman, so be prepared. She's going to give us an update, and then we are going to move on to our guest speakers.
Well, welcome everybody. I'm Christian Davis Furman. I'm the medical director at the Traeger Institute and our Republic Bank Foundation Optimal Aging Clinic. And so first I want to just tell everybody, you know, the governor last week on Wednesday made an announcement that clinics were going to open yesterday, Monday, and clinics and diagnostic radiology testing was opening yesterday. So U of L Health and University of Louisville physicians did follow the governor's guidelines and started reopening clinics and diagnostic testing yesterday. But for our specific clinic, our Optimal Aging Clinic, we decided to kind of keep doing what we have been doing. And that has been really having a skeleton crew in the office in the morning. So we are seeing patients in the office in the morning if it's approved by the provider. We don't want just people walking in randomly. We want them to make an appointment, and we want them to be screened by the provider. So we're doing mostly telehealth all day, every day. We have 2 or 3 providers doing telehealth, so we're able to get people same-day appointments. It's really worked well. Telehealth has really worked well. It's like doing a home visit. You can see people in their home. You can see their kids' pictures on the wall. You can meet their spouse that you've never met before. You can see their medications in the bottles right there, and they can go look at their bottle and read off the bottle and tell me exactly what they're taking. So it's really been great doing telehealth, and we're going to keep doing telehealth. So our office is open from 8 a.m. to 12:30 every day for our skeleton crew, and then the rest of the time it's all telehealth. So our behavioral health people are doing all telehealth, and our geriatricians and our internal medicine faculty are all doing telehealth. But when we are coming into the office, I just want to remind everybody what we've been doing is the waiting room is now really your car. So we're asking people to wait in the car. If people are getting dropped off by TARC, you know, we do have our waiting room set up where they're 6 feet apart and there's not that many people, which is good. We are having people come in the morning to get labs and to drop off their urine samples. And so our lab is open. And then also we're having people wear masks. So all of our staff are wearing masks. And then we're asking all the patients, if you have your own cloth mask from home, you can wear that. And if you don't have a mask, we'll give you a mask when you arrive. So we're having everybody wear masks. So that's the clinic. We had this checklist, like a 3-page checklist to prepare people to open offices. And so it's a lot to go through. So we're working on that through the month of May to kind of figure out how slowly to reopen our office more. But telehealth is working so well, you know, we're not sure if we're ever going to go back. So I don't know. To be determined. We'll let you know more next week. But right now we're just doing the same telehealth that we've been doing. I also want to show you that home health now, you know, Medicare relaxed a lot of these guidelines and all these barriers. So, you know, Medicare is now paying for home health. I'm paying for telehealth they wouldn't pay for before, but they're also paying for more home health because, you know, for home health, you had to be homebound. We're like everybody's homebound now, right? Everybody's in their homes. So, so Medicare said individuals with conditions that make them more susceptible to COVID, so older adults, chronic conditions, are contraindicated to leave their home. They should be staying at home. So they now meet CMS guidelines for homebound status. So we're able to use home health more than we were before. So just keep that in mind. You know, we can do home health more if you have patients. I had a patient I cared for recently. They got discharged from the nursing home. And usually I've made a home visit on them, but we're able to do it all through telehealth and home health, and it worked out well. So I just want to remind people too, you know, speaking of telehealth, we did send out a telehealth survey through our to all of our patients through our marketing department. So if you've used telehealth, if you've been a telehealth patient with us and haven't got the survey, please let us know, because we do want you to take that survey. And I just want to remind everybody, AMDA, the American Medical Directors Association, put out guidelines for screening patients, and CDC just changed their guidelines. You know, at the beginning, the symptoms for COVID was cough, fever, cough, and shortness of breath. Those are the big three. Now the CDC has added, you know, chills and shakes and muscle aches, and they've added not able to see a taste and smell. But also AMDA a while back had already added some guidelines. So these are guidelines specific for older adults. And I just want to point out that fever in an older adult is not the same as a younger person. So older adults can't mount that immune response because your immune system is not the same as the older you get, your immune system does not work as well. And so a fever is considered 99 degrees in an older person. So anything above 99 degrees is a fever. Cough, we already said. Shortness of breath, we already said. But also confusion or mental status changes. That's a big red sign, especially with people with dementia or cognitive dysfunction. Always look for confusion or change in mental status. That could be COVID. The muscle aches, the headache, that's what the CDC added. Sore throat, runny nose, chest pain, diarrhea, nausea, and vomiting. We're still finding a lot of that in older adults that have COVID. So keep those in mind. And then we had a question earlier, I'll go ahead and answer, about what normal flu season is versus what COVID season is. You know, just in general, COVID, you know, and the same as flu, you know, most flu is asymptomatic and mildly symptomatic. Same as COVID. COVID, 80% are mild pneumonias, and you know, people get well and do well 80% of the time. For COVID, you know, 80% are non-severe, 15% are severe, where they get, you know, really short of breath, really in respiratory distress. 5% are critical, like when they end up on the ventilator. But people on the ventilator, some get off, but it keeps changing because they keep doing more testing. But it looks about like there's about a 2% death rate with COVID. And with the flu, this is the data from the CDC from October 1st, 2019 through April 4th, 2019, which is really the flu season. So pretty much we're out of the flu season now. But during that flu season, October to April, there is 56 million flu illnesses, 740,000 flu hospitalizations, and 62,000 flu deaths. So if you do the number, 62,000 deaths out of 56 million illnesses, it's a 0.1% death rate. So for flu, it's a 0.1% death rate, and for COVID, it's about a 2% death rate. So that is a big difference. And then since we're going to be talking about nursing homes and long-term care and post-acute and long-term care, I'm on the governor's task force for long-term care, for COVID, not long-term care. And we just put out a document, and, you know, I'll give this to Justin and Natalie and everybody to put on our website. But these are the guidelines for transferring people to and from nursing homes and post-acute and long-term care. And the big thing is to transfer to the hospital if, you know, at the facility they cannot meet the needs. I mean, it's pretty basic, but if you're having airway management, you need more oxygen that you can get at the facility, you can transfer them to the hospital. And also, you only transfer to the hospital if it meets the goals of care of the patient. So some patients do not want to be transferred to the hospital. So we're really trying to get the post-acute long-term care facilities to be able to keep them at the facility, but it just depends on the facility. Some facilities cannot do that. And so the task force is working on having like a, you know, there's already, you know, they built the whole hospital, the field hospital, which we haven't had to use, but there's more places that we can open up, more hospitals. They can open up different floors and different units if we get a big surge. But right now, the curve is really flat and we haven't had that surge. So everybody's been doing their part by, you know, washing their hands. And so that was the big guidance that we put out. And part of it had a like a flow sheet, like a logarithm of what to do. And now there's a 1-800 number. You could always call the health department, but now there's a COVID hotline for post-acute and long-term care. And then also as part of this document, you know, we did put those symptoms, that symptom checklist that came from AMDA, so people know that what a fever is for long-term care. So we did this guideline, and the other big guideline that we published was we're changed the guidelines for the emergency kits in the nursing homes. It used to be you could only have 2 doses of an opioid. Now you can have like 6 doses of an opioid to try to have enough opioids to keep people in long-term care, because a lot of times people do get short of breath, and the opioids help with the shortness of breath. So I think that's what I had for now, and I'll be, you know, at the end able to answer questions, or whenever you want to do it, Dr. Fall, however you want to do it.
Thank you, Dr. Furman. I appreciate the update. We will start with our guest speakers and then open up the lines for questions. You can start typing your questions in the chat, and we will get to them first come, first serve. So I'm very happy to introduce to you two speakers today, Sherry Culp and Natalie Brown-Radtke. Sherry is from the Kentucky State Long-Term Care Ombudsman Program. She is the Ombudsman, sorry. In this role, she heads the statewide Ombudsman Program and provides technical assistance to district ombudsmen. She is a geriatric social worker by training. She brings a wealth of experience to this role, and she also currently serves on the Kentucky Long-Term Care COVID-19 Task Force and on the Kentucky Board of Long-Term Care Administrators. Natalie is the director of the Long-Term Care Ombudsman Program at Catholic Charities. She has served as the KIPDA District Long-Term Care Ombudsman for Jefferson and its surrounding 6 counties since January of 2016. Prior to that, as an associate ombudsman in February of 2015. In April 2019, the agency acquired the Lincoln Trail District and 8 additional counties to her role. She obtained a BSW and MSSW program from the University of Louisville Kent School of Social Work and is a graduate of Leadership Louisville Ignite program. We are very happy to have both of you here, Sherry and Natalie, and I'm handing it over to you to talk a little bit about the crisis in long-term care right now. Thank you. Just take yourself off mute. There you go.
Thank you. Natalie, would you like me to start, or would you like to start?
You can go ahead and start. Thank you.
Okay, thank you. Well, I'm really happy to be with you today, and so glad to see such a large group of people who are concerned about this population joining us today. In case anybody on the meeting Zoom today doesn't know, a long-term care ombudsman is different from all other types of ombudsman. Primarily, the American Bar Association defines this differently because any ombudsman focus on mediation. And with a long-term care ombudsman, we are focused on what a resident wants. So we're consumer focused. And in a regular world, what our programs have done around the country, each state has a state long-term care ombudsman program that's responsible for making sure that there are local ombudsman services throughout the state. And in a regular world, since the mid-70s or so, the long-term care ombudsman makes regular unannounced visits to long-term care facilities, and we go from resident to resident, from bed to bed, explaining what an ombudsman is. It's a Scandinavian or Swedish word for advocate. So we are advocates for the folks that live there. We try to help bring their voice forward. Many times people are severely ill when they're in long-term care facilities and are unable to express their wishes in a way that they can be heard over the routines of a medical establishment. So we work with them, we educate them about what their rights are when we're in facilities. We provide written information to them about their rights. And right now, what we're doing is we are keeping in touch with residents and families via phone, video chats and things like that, because we're not doing on-site visits. So in Kentucky, there are 15 local district ombudsman programs, and Natalie is the director of two of them as a director at Catholic Charities. She's the district ombudsman for the KIPDA region, and she also assists the district ombudsman in Lincoln Trail, Beverly Broaddus, in her ombudsman duties. So, you know, a lot of our work is done in person. You know, I think residents are on average 80 years old. In long-term care facilities in Kentucky, 70% of them are on Medicaid, so they're completely impoverished because they're spending all their money on their care. They're primarily women, more women than men. Women live longer than men. And many of them don't have any family that's involved in their care. So about 60% really don't have anybody involved in their daily life and their daily care. We try to plug that hole. We try to help them participate in their care plan meetings, and we could be resolving concerns anywhere from we recognize abuse and neglect all the way through someone's food choices or their food preferences are not being respected by the long-term care facility. So it's really a wide gamut of things. And we heavily depend on what's known as the long-term care ombudsman problem-solving process to help get these problems resolved. And the biggest thing that we do is because we have familiarity with facilities, even though there's traditionally really high staff turnover in direct care workers and in management facilities, we work to identify who the change makers are, who can get things done for the resident in the facility. So like a classic thing is a resident may not understand the difference between a hospital stay and staying in the nursing home when they first arrive in the facility. And we try to help them understand what their rights are and what the obligations of the facility is to make that a home-like environment. Natalie, would you like to add some information about your local program?
So, I mean, that pretty much is a good overview of even our, because every district, you know, obviously we're going to have similar concerns. We, again, service like the 15 different counties and just whatever concerns the individual has. At the time, I don't know that I can think of anything in particular other than it's a combination of staff and volunteers. And so, granted, between the two different districts, we have, gosh, I don't know, probably over 125, 130 different facilities ranging between family care homes, personal care homes, and nursing facilities. The family care home being the individual that is licensed to care for up to 3 people in their home. So we also go to those homes to check on residents and advocate for them as well. And so between those 15 counties, there's 6 of us staff members, 2 of which are part-time, and the rest is assisted by certified volunteer ombudsman or friendly visitors. And the certified ombudsman receive the same training that we as staff do. It's a 24-hour training that covers a lot of what Sherry was talking about with regards to complaint investigation, residents' rights, long-term care setting, the history of the program. And they have to take a certification test, but also doing the shadowing to become familiarized with the facility processes, attending residents' council meetings where they have an opportunity to air their grievances or you know, have a better understanding of different things that are taking place at the facility, having some sort of input. So again, it's a combination of staff and volunteers working to resolve those concerns. And the friendly visitors, it's 2 hours of training, and they're literally just that. It's a companion, because as Sherry mentioned, 60% of residents don't have anybody visiting with them. So they really serve in that capacity for residents.
Right. I want to say Natalie is leader of the largest local ombudsman program, the largest concentration of long-term care residents in Kentucky is in the Louisville area. So she has the largest coverage area as far as the number of residents go, not necessarily geographical. I think the Bluegrass region is larger geographically. But we all work together. We've been meeting weekly by Zoom. And I just want to share, I just want to plug put a plug in for this if anyone has not heard of it yet, but the Department of Behavioral Health and the Kentucky Crisis Response Team worked with me recently. They have been creating materials to help anybody, professionals, paraprofessionals, first responders, anybody who needs to kind of check in on their mental, emotional health during this crisis, so that we can, put our own oxygen mask on so that we can continue to serve and help the residents that are our priority. For us, I think a lot of our anxiety, ombudsman anxiety during this crisis has been, we are so accustomed to being able to have face-to-face access with this really vulnerable population that tends to, one of the reasons we exist is because there's a power imbalance when you are completely dependent upon others to help you get out of bed, to wipe you after going to the bathroom, to bathe you. You may need somebody to take a fork, from the plate to your mouth. That power imbalance makes it really difficult to share minor concerns and complaints. A lot of residents feel like, if they speak up, somehow they'll be retaliated against or something like that. We don't see a lot of retaliation. We don't see a lot of abuse and neglect, even though we do identify it, and we turn those reports over to Adult Protective Services and the Office of Inspector General, so those folks can make determinations if abuse was substantiated or if a long-term care facility failed to follow federal regulations, state regulations to protect residents. So a lot of what we do on a daily basis helps residents understand their way to participate in their life and quality of life, as well as quality of care concerns. So, like I said, I think around 5% of the 7,000 or so complaints that we work on for the 35,000 long-term care residents across the state, about 5% of them are abuse and neglect, primarily concerns of neglect due to short staffing or something like that. But a lot of the complaints that we work on have to do with rights, since we specialize in talking with residents about those. I have a really good handout from the National Consumer Voice, which houses the National Ombudsman Resource Center in Washington, D.C. And I'm going to share it with the organizers so they can send it out to you after this call. It's a really good chart that I think I'll share on my screen right now while I'm talking to you. Let me figure out how to do this. I'm learning. Okay. It lists the resident rights and how they are. Can you all see a handout that has a lot of green and white? Okay.
Make it a little bit bigger.
Yeah. Let me. How about that? Is that better? Let's see. Make sure. Okay. How about that? Is that a little better?
Yes, thank you.
Okay, you're welcome. Anytime, just speak up if you need me to adjust something. Okay, so over here on the left, we see the issue. This handout is organized by rights. So there's some specific things here about transfer and discharge and bed hold rights. The biggest thing is that during COVID, the Center for Medicare and Medicaid Services waived some regulatory requirements during the crisis. And of course, you can see notice to transfer and discharge is one of the things that's been waived for the reason of COVID. And that's to give facilities the opportunity to, set up COVID-specific wings within their building, or to quickly transfer someone out who might need to go to a facility that has a COVID wing if they don't have a COVID wing. The nursing home associations, I think both American Healthcare Association and Leading Age, encouraged their members who are providers early on to try to set up locations within their building where they could not clinically isolate, but cohort people together who might have COVID or have no symptoms So these changes allow facilities to move quickly and make those accommodations. So over here in the last comment, in the last column are comments from our national organization and about, what kind of concerns advocates may have about these adjustments, these waivers to resident rights during this time. So, one of the big concerns that advocates have been talking about is how are things going to look as we start to transition back to normal as much as we can. So we want to make sure we're working together. Yes, I'm sorry. Did someone have something? Okay. So we are working together to try to make sure that after a certain period of time that residents do get their rights back as far as getting more formal notice with more of a lead time, more participation in the process of making decisions about transfer and discharge. So the comments column is really important to us as advocates. So bed hold notice, some things like that. I'm not certain that Kentucky has expanded the amount of bed hold, but I do think that it's something that we've been working on. As Dr. Furman said, I've been participating on the long-term care task force as well, and there's just it's absolutely amazing. I mean, I'm communicating with people that are in my position in other states. And actually, my mentor, when I became a state ombudsman, I was assigned to Patricia Hunter in Washington State. So I've had the great privilege of being able to communicate with her constantly, either by email or phone, since they had the outbreak at the Kirkland facility. And we know that Kentucky is really doing a lot compared to other states. I know when our national organization reached out to give me advice, they said, try to get your state government to set up a long-term care task force. And I was like, done. They've done it. And there's, absolutely amazing people on the task force. I'm one of the only people who's not a physician. They have, an immense amount of respect for residents' decisions, some of their end-of-life care wishes, and those being honored. There's been quite a bit of discussion about how to serve residents who don't want to go to the hospital at the end of life or don't want life support and things like that, and not forgetting those wishes and trying to honor them the best we can, so that people don't go through pain and different things at end of life when they don't want to extend. So there's really been a tremendous amount of work to try to address things like transfers and how they're handled. And like Dr. Furman shared, the memo that came out from the task force, which was, I would say, 2 weeks of nearly every day, maybe every other day, of meeting and talking about what does it mean to transfer folks back? How can we get residents back in long-term care facilities? I think we recognize that long-term care facilities were really scared about taking people in, understanding more about testing, getting residents access to testing, and I hope there's some more guidelines that'll be coming out real soon. One of the things that was waived by CMS was a requirement for nurse aides to finish up their mandated training certification requirements within 4 months of beginning the work. And so that's been extended. From an advocate's point of view, I mean, we're always worried about nurse aides being undertrained. About 90%, maybe 95% of the work in long-term care facilities is the direct care is provided by nurse aides, and many of them just have a couple weeks of vocational training. Some of it's done on the job. A lot of our complaints, when you drill down into the case journals, you can see that some of the problems were a result of there not being the correct support for this level of staff. They're not RNs, they're not trained in assessment. they're trained in how to do tasks. And so as an advocate, you know, it's concerning that, you know, residents may experience care by more folks who don't have all the training that they need. But it's a bigger concern that there not be enough staff to serve residents. We want to make sure that facilities are comfortable. It is not common for a long-term care facility. I don't know, maybe I started in this program in 1996 as a volunteer, and maybe a couple times during that entire time have I had a facility willingly admit to me that they don't have enough staff. Most commonly when we approach a shortage of staff problem in a facility, the first thing is, we don't have that problem. No, look at this schedule that we've created. We can't help it if people call in. A continual denial that there's a shortage of staff. We worked a lot with the legislature this year. Some of the things, one of the things that we're responsible for doing is systems advocacy. We're supposed to monitor state agencies, whether or not we feel like they're serving residents correctly. We do that a lot with Adult Protective Services, Office of Inspector General, and guardianship, monitoring their services to residents. And we know that a lot of folks are just not accustomed to saying that facilities don't have enough staff. I think there's been a big concern about liability related to that. And also, Kentucky is one of the states that doesn't have a staffing standard beyond what the federal government has, which is there has to be enough staff to meet the resident needs. And there has to be an RN on staff 8 hours a day. We have been utilizing research that's been available for the last 10 years. I'm a huge fan, if any of you all are fans of researchers and their studies, I'm a huge fan of Charlene Harrington, who is a PhD nurse out of the University of California, San Francisco. She has done some amazing studies on staffing and worked with John Schnell from Johns Hopkins and some other folks. And we know from years and years of studies that it takes about 4.1 hours of direct care per day per resident for a resident to not suffer an unnecessary decline. So we have tried to get our legislature here in Kentucky to adopt that. I've worked a lot with Illinois and their state long-term care ombudsman program because they passed that legislation. And, you know, this year we were really blockaded by overall workforce issues and providers leading the discussion into how do we deal with there not being enough people to meet the workforce needs of healthcare overall. And that kind of diverted the attention from what we were trying to do. We really spent a lot of time near the end of the session looking at what workforce programs are available out there. If it's beneficial to anyone who has an interest in staffing, I'd be happy to share. I think we did an assessment with the legislator, and I think there are 11 pages of healthcare workforce development programs that I can send to anybody. So there is a lot for workforce development in healthcare. So, you know, maybe it truly is time for us to think about putting a standard in place. And with that standard, we always say, not only do you need enough nursing staff, they need to be trained better. We need more training requirements, and they need proper supervision. And another thing that we always advocate for is that an RN be in the building 24 hours a day, because a lot of facilities use their RN that's in the building 8 hours a day to do administrative paperwork and things like that. So we know with COVID that residents really need to be assessed quickly and effectively. So having that RN level of nurse in the building 24 hours to us is really important, and to the residents and the families that care about these residents. Another right that I want to point out quickly here is roommates and grouping residents. So traditionally residents have rights that if they're going to have a roommate change or they're going to be sent to another part of the building, they get notice, they get as much orientation to the move as possible. They have input into whether or not they want to room with someone, a particular person. But during this time, those rights are waived because we you know, we recognize that people have to be moved around rather quickly sometimes. There's a little bit more about that. In regulation revisions during 2016, there are phases. The federal regulations were revised for the first time since the 90s at the end of the Obama administration. And with the change of administration, advocates were really worried that all those regulations would be rolled back. Several of them were like regulations that had to do with arbitration agreements, forcing people to sign arbitration agreements. Some of those things were put on hold. But some of the good things that went into effect rather quickly were some changes about care planning. So we had a new regulation that facilities have been working under for the last few years, that they should do a care plan assessment of a resident within 48 hours of admission. And I really think for many years we saw folks who suffered a lot at the beginning of a nursing home placement if the facility didn't have their ducks in a row and they weren't doing a good job at communicating orders from the hospital with their medical director who may be adjusting those orders. Some facilities have pharmacies that are hours and hours away from their building. And sometimes I know my best friend, right before she passed away, she went into a facility owned by a really large corporation, and they had a pharmacy that was 2 hours away from the facility. And so she had been a diabetic since the age of 21. She was 65. And I think for the first time ever, she went 4 days without insulin. And she was a dialysis patient. And so it just really floored me that the facility, upon admission, didn't do what they had to do to get over the fact that their pharmacy is too far away and get her on those important medications right at admission. So we know that an assessment, even if it's a brief or basic one in the first 48 hours, is really important. But I think that CMS was really concerned about facilities being able to handle a surge of a lot of new admissions, and having some of the staff that would traditionally work on baseline care plans with residents might be doing some direct care because staff are sick or there's other reasons for shortages. So we understand it, but we really want to make sure that this comes back as soon as possible as the crisis changes. So there's some more information in here about the comprehensive care plan, physical environment, not requiring a 3-day hospitalization stay in order to get Medicare to kick in and pay for skilled nursing facility coverage. This has been a huge issue for several years because sometimes when hospitals admit folks, they keep them under observation status instead of a full hospital admission. And then that would really interfere with folks being able to access their Medicare benefit, which pays for a short period of time for a person to have skilled nursing services. So this is really glad. I'm really glad about this. I would like for this to stay, really. I think that requiring a 3-day hospital stay is kind of archaic in order to get someone's Medicare to kick in for payment. This may be something that we can work with nursing home providers and the industry trade associations on. As advocates, we're always looking for ways that we can partner with these groups and try to improve things for residents. So the 3-day hospital stay in order to get skilled nursing payment to kick in through Medicare has really been a big barrier, especially to some folks who primarily are not able to stay at home and have ended up in the hospital because their dementia is too difficult to manage at home, and they may not have a skilled nursing need that would help them utilize their Medicare for a short-term stay. We're a little bit concerned about this data submission. We don't think that the things that the Centers for Medicare and Medicaid Services ask facilities to report is a burden. But there was something in the situation with COVID that caused CMS to want to suspend some requirements that they had for data that they usually require facilities to send to them rather quickly through electronic transport. So one of the things is payroll-based journal staffing data, which is right here at the top of the page now. since we don't have staffing standards in Kentucky that go beyond the federal requirements, I think it's really important that facilities continue to report from their payroll data instead of their scheduling documents, what staff are actually at work providing direct care to residents. And I think that CMS really made a mistake with this one, because I feel like in a pandemic, when we decompress afterwards and we start really looking at lessons learned, I think that we're going to be really sorry that we didn't have a better picture of what was going on with the staffing in facilities. I think that it would, if it was continually being collected, I think it would help a lot of folks make decisions about where to send staffing teams. I know there are some volunteers and students and some people who haven't been working regularly in their medical field that are available. And I know that we all have a lot of concern about facilities admitting, I don't have the staff I need, send me some extra staff. So I feel like this could have been a real tool in helping determine that. So I'm hoping that that's suspended rather quickly, and we can get back to understanding more about staffing in facilities. Physicians visits, using telehealth, as Dr. Furman said. Yeah, I mean, telehealth has been wonderful. Almost everyone I know has used it for one reason or another during the pandemic. I think it's something that helps a lot of residents who have severe mobility issues to be seen by their physicians. I know that we have a lot of folks who are rather young in nursing facilities who really want to utilize one or two experts in the state to help them with their MS. And it's difficult to get to those specialists sometimes, to those appointments, because of transportation or just pain and mobility problems. So telehealth is probably going to be a wonderful thing that we see expanded as a result of COVID, and I hope that keeps going. And these pre-admission screenings have been delayed for a little while. And the pre-admission screening assessment tool is something that traditionally residents need right at the time of admission. PACER folks really focus in on, are we sending somebody into a nursing home to live when they really could be in a less restrictive environment because they primarily have a developmental disability or a mental health need. Years ago, there were two women in Mississippi who sued the state of Mississippi because they were developmentally delayed and they had been forced to live their entire lives in nursing homes, and they really didn't need to be in that restrictive of an environment. So all the states have had directives to try to work towards making sure that we're not just sticking people in nursing homes that really don't need to be there. So I think it just makes sense for this to be relaxed a little bit at this time to help people who need to get into long-term care facilities because they're on their way to, recovering from COVID, or COVID has caused them a setback and a decline in their overall health, and they need to live in a long-term care facility from now on. So these are some really good resources. Here's a link down here to the organization that we got these from. I've been on the board of this organization. I've worked with them my entire career as a long-term care ombudsman. They're a very reliable source for information, and we utilize them to guide us as ombudsmen at all times. So also, when you go to their website, they have a nice map that lets you know who the long-term care ombudsmen are in other states. So that's really helpful because I know many of you may have family and relatives who are in other states that you want to try to get them help. So here's another view of their website to gather information off of. Let's see, Natalie, do you have some things that you would want to add?
Yeah, so just to kind of touch on some of the things that we're seeing throughout this pandemic right now, and especially not being able to make those visits for us, that is challenging. I think we've always been creative about how to address resident issues, having you know, such a large area to cover, and just having to be creative with minimal staff to do that. And so we've always kind of woven in the phone conversations or emails when possible. But, you know, of course, at that time we were able to make the physical visit to see exactly what's happening, because sometimes staff will tell you that they're doing X, Y, Z, or that they have sufficient staff, as Sherry mentioned, but sometimes when you go in and you see something totally different with call lights going off constantly, and whether or not staff are attentive to that. So that is a challenge throughout all of this. But we're being creative. As she mentioned before, we're also using you know, the video chatting component to be able to still attend care conference meetings, and oftentimes still being able to see the resident or to chat with residents and to see how things are going, being able to video conference with them. Some of the concerns that we continue to see, food has always been an issue in certain facilities, and so now that's even more of a challenge now that facilities are being restricting family members from bringing items in. And so having to navigate that, and, you know, facilities, in many cases that we're hearing, they're trying to be creative about finding out, you know, what each resident in particular likes, or, you know, what are the concerns with whatever the meal is, and trying to accommodate as much as possible. We've seen issues about whether or not trash cans are being emptied or rooms are being cleaned. But part of that is also looking at some of the guidance that came out about minimizing how much contact, if you will, that you have with the resident or their space. So, and again, that's something that's very challenging to physically see sometimes, unless we're able to video chat to kind of get a view of what their actual environment is like, but still having those conversations with residents to let us know what's happening, or with family members to try to address concerns. I'll say a lot of what we see, some of them are no different than what we've seen before this. And then of course, with all of these restrictions in place and just the concerns about, you know, what's happening in their facilities, not being able to see their loved ones. So we're really encouraging you know, donations even, because some residents don't have cell phones to be able to communicate more regularly with their loved one, and not having to rely so heavily on staff to make those connections. Working with the facilities on being creative with providing meaningful activity. It's really starting to take a toll on residents being isolated to their rooms primarily for such extended periods of time, and still encouraging staff to be creative, you know, that it's okay to take residents out for a walk. You know, the weather is getting really nice. You still maintain that social distancing aspect, and that'll really help, because we really don't know how long we're going to be in this situation. And so wanting to try to not only care for their physical needs, but their mental health as well is just as important. And the room changes, I've already seen some concerns around that. Because as Sherry mentioned, you know, before we were able to advocate more for residents and trying to keep them in their current room for different reasons. And so now, you know, we've seen some where people had, you know, doctor's notes to allow them to have a private room and still have Medicaid pay for that based on their medical needs. And so still having to work through some of those challenges, because, you know, in that particular case, whether that person still had to be moved, but at least not to pair them with another individual and allow them to still maintain that private room. Or the concern of, you know, people being moved, and maybe there wasn't a specific medical need that required them to have a private room, but yet they've had that private room. They were given that room in the beginning of their stay, and worried about whether or not these room changes will sort of allow facilities to sort of push their own agendas, if you will, because now there's this flexibility to be able to move someone. And so whether or not, once this is all over, whether or not that person will be able to go back to their room. So really working through that. Does anybody have any other specific questions that we might be able to answer?
Yeah. We have a lot of questions in the chat. I'm going to ask Justin to start reading the questions, and then we can get going with that.
Okay.
Okay. So first I want to say that there are several resources mentioned in the chat, and this will be shared on our website, tragerinstitute.org, as well as the resources that Sherry mentioned during her presentation. And Natalie, if you mentioned anything or if you all have any resources that you'd like to share on our website, please send them to Natalie, and we'll make sure that that gets posted with the video of today's discussion. I'm going to move so I'm not backlit, so I don't have a light behind me. So,
Justin, we don't see your picture at all, Justin. I don't think. Maybe other people do. There you go. Okay.
I was backlit, so I wanted to make sure that it wasn't glaring. So Barbara has a three-part question. So we're hearing stories of nursing home facilities, residents being dumped on family members because after discharge. How can the Ombudsman help families with these situations? And then how basically nursing staffing ratios have always been a problem. How's it being ensured that basically staffing ratios are adequate during this crisis, specifically due to social distancing? And how do we make sure that residents are getting the care they need during COVID-19?
So this is Dr. Furman. One thing I just want to say for the Louisville market, Summerfield Nursing Home and Hill Creek Nursing Home are COVID facilities. Mm-hmm. So the families, I think, do have to push. It's okay for the families to push back and say, no, I can't take my loved one home. They have to stay in the hospital until they get into a facility they can take them. So, I mean, they can get into Summerfield, they can get into Hill Creek, and that's in the Louisville market. But throughout the state, I think there's like 2 other facilities. I don't have them off the top of my head, but there are facilities that are designated COVID facilities or have a COVID unit or a COVID cohort. So if the nursing home, it's always been a lifelong between the nursing home and long-term care, like get them out of the hospital, get them to long-term care, and then the long-term care can't take them, and where do they go? And I think the families can just be strong and say, I can't take my loved one home. But then I think, like Bluebird said, that they do have other agencies that can help people at home. But it's okay to push back as a family member and say, no, I'm not taking them. I'm not taking them home. Because I think the families feel like they have to take them home, but they can say, no, I can't do it. I mean, I don't have the resources. I cannot do it. So they will stay in the hospital until they have a place to go. We've had people like in the hospital for a month waiting for a nursing home. So, I mean, it's not ideal, but it's not ideal to go home and have a disaster happen either. So.
And definitely being able to call and get us involved to the extent possible of being able to work through some of those challenges, because a lot of times it's easy for the facility to try to, or the hospitals, whomever, to create this picture for the families, and then, they not know. And so they just go along with whatever is being told to them. I think this situation that we're currently in has created an interesting dynamic, because we are limited in many ways to where some people can go. But hopefully with the new guidance that was sent out, because even the person that, had tested positive previously, but now they test negative, and still being able to try to get into some of these facilities, because a lot of them, or at least several of them, have created at least a quarantine area in their facility where they aren't once they have that transfer into a facility, being admitted into a facility, that they're going to be quarantined anyway for a period of time. And so if they have a negative test result, that hopefully they could be able to be in that quarantine unit to make sure that everything is okay, if the facility is able to still meet their needs care-wise, and then have them move into the general part of the facility to free up that space for anybody else that may be needing to be admitted into the facilities.
And I will say one thing that came up during this long-term care task force is that there is this there's like this pandemic standard of care. Like you said, all these rules and all these things are changing because of it's the pandemic. So that's the question, is when are we going to get back to like not pandemic times, because right now the state is starting to open up. I mean, the clinics are opening up and diagnostic testing is opening up. The nursing homes are never going to open up. I mean, they're going to be locked down, like no outside visitors, because that is where there's a hotbed. I mean, it could just spread like wildfire. And then, these are very vulnerable patients and they'll probably die, which is very sad. So we don't want that to happen. So you're trying to balance it. That's why they don't want to have anybody that's not an essential worker. And I know that came up in one of the questions, is like, what about these facilities that aren't letting caregivers in, and then the patients aren't doing well because they don't have their caregiver, and these caregivers are not considered essential employees? I mean, maybe you can make the case that they are essential. The patient's going to die and decline without this patient. So it is an individual thing. I think you're going to have that conversation with each facility. But, you know, now that we are kind of starting to open up, you know, if you could wear your mask the whole time, and not touch your face and wear your mask down around your chin. I mean, if you wear your mask appropriately, that should be enough, you know? So I don't know. It's just depends on each facility and how well they can, you know, handle the situation.
It does. And I will say that we have seen instances, you know, if you can outline the care that is specifically being provided by that individual versus just sort of sitting with that person. If there's specific care that's been provided and assisted, but we have seen some cases where facilities have allowed that individual to come in and still provide that care. But again, you know, as you mentioned, it's different for every facility, every person you talk to, you know, they're kind of interpreting some of these things very differently. Definitely, I believe out of fear that, you know, something is going to happen. We've seen a lot of restrictions, even in terms of whether or not vendors are going to be allowed to come in and, you know, even refill snack machines or Coke machines. And so, you know, just again, when we talked about providing support, whether that's if, you know, and again, facilities interpret things differently, but even donations being made as far as snacks to residents so that they still have some sense of normalcy throughout all of this, and they still have those comfort things throughout all of this. So again, every facility is interpreting some of these things differently, but definitely having some of those conversations.
I just wanted to kind of address the staffing question and comment. You know, it's very difficult for anyone from the outside to monitor the staffing right now. So, you know, we have tried to utilize social media. Our email list contains quite a few direct care workers because our organization has provided training to direct care workers in the past, and many of them registered online. So we're trying to reach out and make sure that those folks can be whistleblowers, you know, let us know if there's a really bad staffing situation going on in the facility that they're working in. But, you know, we're not in there to catch the short staffing. Families aren't in there to catch it. And the Office of Inspector General, I mean, I think the only way that they would catch it right now is if they were in there doing an infection control survey and realized that there was a short staffing problem that was contributing to the inability to have good infection control practices. So I know every reporter that I've talked to in the last month, I've tried to make sure when they say, you know, is there anything else you want to share, that there are a lot of really good people who work as direct care workers, who work as nurse aides, housekeepers, food prep workers in long-term care facilities. Many of them on the socioeconomics, you know, rung scale, they fall really low on there. I know right before COVID changed everything, I was in a long-term care facility that had 117 employees, and I think 18 of them, the administrator told me, were in active domestic violence situations at home. And, you know, so we need to do nice things for people who work in long-term care facilities, as well as some of the nice things people are doing for residents, sending them cards and things like that. But a lot of these direct care workers, they're picking up extra shifts, and it would be really nice, you know, somebody or suspect that somebody works in a long-term care facility, see if there's anything that you can do for them, maybe pick some things up for them at the grocery, provide things that would help their children be entertained while they're working extra shifts. Yes.
So I just wanted we have about 2 minutes and we have 2 questions. First, Mona asks, she noticed that there's a lot of MDs on the task force. Are community members or families able to be a part of this?
Now, I don't think that they put any community members or families on there. I know when I was asked to join, I think they were trying to recruit someone, me and someone from AARP to be a consumer voice, but I don't think AARP ever joined. So.
And Yeah, this is Dr. Furman. I'll ask that because I think you're right. You want the patient and also a patient representative, you know, a patient or family. So I think it's always good to have that voice. So yeah, we can ask that question.
And Dr. Furman, can you briefly answer Colby's questions?
Yeah, so Colby was asking about the antibody test and its usefulness. You know, that's still to be determined. I mean, even at U of L, you know, it's like you're testing for the IgG and IgM, and the IgG is like you've had it way, way long ago, and IgM is more recent. So how they don't even know what to do with this testing yet. But the only place you can get testing right now is at the hospital, and be wary of anybody that's asking for cash testing. So it's, you know, we don't really have it in the doctor's offices to do antibody testing. And I think you're right, it's too early to know about this vaccine. You know, I think they will get a vaccine. It depends on when, and I don't know when that will happen, but I think there will be a vaccine. And the governor's mandate to wear a mask in public, you know, there's different masks. There's a surgical mask, which are usually like blue or yellow that just kind of go around your ears like this. And that's what they're recommending to use, just everybody in the hospital, everybody in the clinic, that's the routine mask. The cloth mask they're wearing, that's what you should wear like to the grocery store, just out in the community getting gas. And then the N95 mask are what you should wear for if you have a COVID patient that's suspected or positive COVID, which is protects you against the aerosol, you know, these aerosolized procedures and the aerosolization, which the COVID is spread that way. So, and the cloth mask with these filters sewn in, they're really no better than just like a regular cloth mask per se. So the cloth masks are not for people, if you really think someone has COVID, you don't use a cloth mask. The cloth mask is for us, like me, to maybe I'm an asymptomatic carrier, so I don't spread it to somebody else. So the general public, you know, they are giving away masks at some of these COVID testing sites because we want everybody to have a mask, and not everybody can make their own mask. So they are starting to give those away more. And then I think that was it. The stress on staff and what we're doing, I think at a lot of these facilities, you know, because of the social distancing, everybody's having one-on-one feeding. So like administrators are starting to feed patients, administrators are delivering trays. You know, the driver, they're no longer driving people to appointments. The driver is now checking people's temperatures. So I think everybody's like working in different ways. But I will say that this whole thing about being able to police the nursing homes and for the nursing homes to be honest about their staffing issues. This came up at our task force. A lot of nursing homes are afraid to ask for help because they're afraid then they're going to get a survey, or they're going to get in trouble. They're going to, and so, you know, it's this culture that's been there of punishment. And so the governor's task force and the governor's office is really trying to change that mindset. It's like, we're not trying to punish these facilities, we're trying to help these facilities. So please, if you know facilities that need help or you work at, please, they need to ask for help before it's like a crisis situation, because there is like 400 people. They have this volunteer task force. They can send medical students, they can send retired physicians, they can send retired nurses to help, and they will do that. So, you know, please, if you have the ability to influence nursing homes, you know, they need to ask for help when they need it and not think they're going to get punished because they have short staffing.
Thanks, everyone. Unfortunately, we're at the end of our time today. Thank you for a lovely discussion. I just want to remind you that next week we're going to have a guest speaker talking a little bit about social media and all of the, how to navigate all of these different informations we receive on social media about COVID-19 and how do we manage this. Is this good information? Is this bad information? So that will be next week. If there's anything else that you want us to talk about, please send us an email and we will make sure we get a speaker to talk about it. Thanks everyone for being here with us today, and we'll see you next week.
I really learned a lot. Thank you, Sherry and Natalie.
Thank you.
Yeah. Bye.
Bye.